This is going to be one of those important discussions that is a few years ahead of its time. So don't be surprised if you've never heard anything about this or that you will hear about it in the next few years. So I'll be talking to you about a condition, as I said, pulmonary hypertension, and I'll be sharing with you some insights. This is from the Cleveland Clinic about what it is and why the numbers are going off the scale. So, as I said, this is based on my analysis of years of admission statistics, looking at the outcomes, looking at the trajectories, and therefore being able to predict based on the autoimmune paradigm as to what is likely to happen. What diseases are we going to see a surge of? And this is one of them. So, this is big because the truth is that we don't have any solutions for this condition. So the reality is that when this happens, we are going to have to explain to people that, listen, there's not a lot that we can do about it. This is just what it is. So first, I'll take you through some basic anatomy. Then I will show you the pathophysiology around what it is, and then I'll show you what the statistics are coming out of the UK. So just a few basic things. When we think about the heart and the lungs, and what we're talking about here is the pulmonary arterial system. And so, what you can see here is the heart, and you can see the blood vessels there with regards to the lungs. I'll come back to that because I think I need to make my mouse pointer a little bit bigger for you to be able to see. So the point though is that when we think about the way how the heart works and what happens is that you have to get the I'll just make this a little bit bigger here. There we go. This is perfect. Okay, so let's look again. When we look at the heart, the blood comes from the venous system. So it comes from the legs and the abdomen down at the bottom here. This is the inferior vena cava in blue. Comes in from the superior vena cava. It then has to go, because it's from the venous side, it has to go to the lungs to get oxygen. So it is pumped from the right hand side of the heart. And I'll show you this in a minute. This is the blue part. So this is still deoxygenated blood, low levels of oxygen. And it then has to be pumped to the lungs where it then gets oxygen before it comes back to the heart and it's pumped around the body. So this section here in blue represent your pulmonary arteries. Now, this is also where, if you're going to have a clot on the lungs, pulmonary embolus, this is where it's going to be sitting. So, massive clots can block. And so, this is a pretty serious condition. But the main point is that the pressures in these arteries are usually much lower than the pressures, say, in the aorta that pumps around the body. But what we'll be looking at is disease affecting this blue area of the arterial system. These are the pulmonary arteries, what we would call pulmonary hypertension. Here is another image in a little bit more detail. You can see again, these are the arteries that are coming from the heart, taking the venous blood, taking them to the lungs so that they can get oxygen. After it's been oxygenated, they come back to the heart and then they're pumped around the body. Again, as I said, nice and straightforward, a beautiful system, but it is dependent and it works best when the pressures are normal where they should be. Here is another example, just so that you get the picture. When we look, you can divide the heart into two. Well, it's technically four chambers, but we're cutting it in half: right ventricle and right atrium, left ventricle and left atrium. When the blood is coming from the legs and the head and the neck, the venous blood, it comes into the right atrium, goes to the right ventricle, and it's pumped through the pulmonary system. It then comes back from the lungs to the left atrium, goes to the left ventricle, and then it's pumped out of the body. Where we are concentrated is this aspect of the presentation: the right side of the heart, the right atrium, and the right ventricle. And this came up from a discussion that I had with someone recently. They were specifically focused on a product, Molecusan Medicinal Stein. It's Joachim Gerlach. And as he was talking, he was making a presentation, something jumped out at me with regards to valve disease. Okay. Now, let's just take you back a minute because this is an important point before I show you the statistics. Here is here are the valves. So this valve between the right atrium and the right ventricle is the tricuspid valve. When the blood is pumped from the right ventricle out through the pulmonary arteries, there's another valve like this called the pulmonary valve. On the left side, this is the mitral valve, and when it's pumped from the left ventricle, it goes through the aortic valve. And the valves are there, they're one-way systems, so that even when this heart contracts, nothing can get back into the atrium. It can only go through the other valve. It's a one-way system, okay? And what was noticed is that there was an increase in tricuspid and pulmonary valve disease. That made no sense. Why would those valves be affected? And so this is therefore when I have about 9 to 10 years of data that I can analyze looking at trends. And this is why I'm able to pick these things up before nobody else does. Because if you don't know what to look for, you will not realize it's a problem until it jumps out at you. And this is why we need to understand the pathophysiology around the pandemic in order to predict what's going to happen next. So when I looked at the heart valve disorder trend in the UK, you have different ICD codes, I-34, I-35, I-36, and each one represents a different a different condition. So non-rheumatic, meaning rheumatic fever causes valve disease in children especially. And so you're looking at non-rheumatic mitral valve, aortic valve, tricuspid valve, pulmonary valve, and then you see here rheumatic, mitral, aortic, tricuspid. When we looked at this here, what I saw standing out in red was the massive increase in tricuspid and pulmonary valve disorders. Okay. These also went up, mitral and aortic, and we're looking at the trend from 2016 to 17, the average 2024 to 25. So you can see that these are big numbers. Unlike, say, rheumatic aortic valve disease, these are small numbers. But when it comes to the non-rheumatic valve disease, huge increase in tricuspid and pulmonary valve disorders. This was exactly as it had been stated to me. So I knew that this was very, very relevant. Okay. So my point was that when I looked at that characteristic, I thought that it's not going to be something directly affecting the valves because it should then affect most of the valves about equally. This was something that was primarily affected the right-hand side of the heart, the pulmonary valve, and the tricuspid valve. So the thought that came to my mind was that this was going to be pulmonary hypertension. So what is it? So before we go on to the other set of statistics, I'll just give you some insight into what from the Cleveland Clinic, pulmonary hypertension. What happens here is high blood pressure in your lung arteries. It can result from heart disease, lung disease, a number of other conditions. We'll come to the symptoms in a minute. And in it, you can see here a normal pulmonary artery. But in this case, this artery is damaged. So therefore, it's harder for blood to flow through it. And you have higher pressures. These pressures then impact the right-hand side of the heart because it has to work harder to push beyond it. And as a result, you would see problems with the pulmonary valve and the tricuspid valve. It's usually a complication of heart or lung disease. And when they looked at the WHO classification, there are a number of different groups: group one, two, three, four, five. And I'll come to this in a little bit, but it's showing you the different causes of pulmonary hypertension. What are the main symptoms? Chest pain or discomfort, dizziness or fainting, fatigue, loss of appetite, shortness of breath, swelling of the legs. Now, people will look at a lot of these symptoms and say, oh my goodness, I've got some of these. Could I have pulmonary hypertension? It's not as straightforward as you've just got a few of those symptoms, so you've got pulmonary hypertension. What you would find is that if people have persistent shortness of breath, with exertional patterns for which they have already been investigated for other things, can't find anything, sometimes either an echocardiogram can pick up increased pressures in that right hand side of the heart, or they need very specific tests to look at the pressures. So, very often, it's a diagnosis that comes about when all the other commoner causes have been identified. So, you don't want to miss angina thinking you've got pulmonary hypertension. And so this is what I mean, is that it's not usually the first on the list. It's usually after you've investigated other common causes of shortness of breath that you would then, if you can't find a reason, you would then go to look to see whether or not pulmonary hypertension is a cause. Now, what I've then done is I've found a paper here that was looking at the latest definition and classification of pulmonary hypertension. And this is from Australia, was done in 2024. And what was standing out to me was this section. When we looked at the table in terms of the clinical classification, group 1, group 2, group 3, group 4, group 5, and when we think of group 1, these are usually people who have genetic or congenital disorders, and it also has the idiopathic group. Group 2 are people who have left-sided heart disease with increased pressure on the right. In group 3, this is the group I'm very interested in, because if they have restrictive lung disease, which is what I'd expect post-pandemic, lung disease with restrictive and obstructive patterns like fibrosis, worsening COPD, these will be associated with pulmonary hypertension, as well chronic thromboembolic pulmonary hypertension. This means chronic clots forming in the pulmonary arteries and raising the pressures. So I've highlighted these as my thought as to the likely reason why we're going to see this massive rise in breathlessness, because this will be the problem. People will say, I've got breathlessness, and nobody seems to know what the cause is. So here is where I now take apart. This is no longer just a hypothesis, meaning that some people would say, wait, you're talking about pulmonary hypertension as if this is what is happening, but there is no evidence that pulmonary hypertension is actually increasing. So it's purely an idea that you are extrapolating on because you believe that the autoimmune characteristics around COVID and ACE2 will damage these arteries and therefore increase the pressures and cause right-sided heart failure. This would be purely hypothetical, just a theory. The problem is that I've got data. So when I look at the data, and this is again the trend in the UK, this is now the ICD code for pulmonary hypertension. As I said, there are many causes, I-27, and then it's broken down into 0, 1, 2, 8, 9. The two that stand out to me are that I-27 overall, pulmonary heart disease, all the subcodes, has increased by 59% between 2016-17 and 2024-25. Most of that change occurring post-pandemic. As well, other secondary causes of pulmonary hypertension has increased by 70% from 80,000 to 137,000. These are not small numbers. And the point I'm making is looking at this trajectory, it's going to be no surprise that we see a massive rise in this kind of disease. Now, why am I making reference to it and why am I raising awareness? Because if you don't know, you can't mitigate. Because what is happening at the moment is that the medical and scientific community has become very reactive. Oh, there's a problem here. Let's try and figure it out. No, you don't have to be reactive. You can be proactive if you understand what the problem is. But there's a reason why they're being reactive. It's because in order to be proactive, you would have to extrapolate beyond just infection, and you would have to include other things that could be a problem. And this seems to be where the problem lies, in that we have got an elephant in the room. Everybody is baffled. They have no idea why we have such remarkable transitions in terms of diseases. It makes no sense. The only thing they can think of is infection, but they are not noticing the trunk on the elephant. That's the problem. And this is why we have become far more reactive instead of proactive to be able to identify these kinds of problems. This is just where we are. And I don't have any simple answers other than to raise the awareness of what is likely to happen. So, in summary, I am predicting that we are going to see a massive ongoing surge of pulmonary hypertension. If you've come late, what we're talking about here, other than the elephant, is this: the arteries here that are taking oxygen to the lungs so that they can get oxygenated before they come back to the heart are under pressure. Instead of hypertension affecting the systemic circulation when you do your blood pressure, this is hypertension affecting a hidden part of your body, the pulmonary arteries. This will then put a strain on the right side of your heart, which will be associated with particular symptoms like persistent breathlessness in people who don't have any clear explanation for their problems. This is likely to touch close to every one of us, because if this continues to rise, you're going to find those family and friends who have been going to their doctor. Yeah, I'm short of breath. I don't know why. Nobody seems to know what's going on. They haven't found any problems. They've done all the investigations. It all seems to be okay. So you are now in a position where you can suggest something that may be relevant. You may be able to say to them, listen, when you next go to your doctor, mention the word. Is it possible that this could be something like pulmonary hypertension? Again, be careful how you mention it. Doctors don't like you to give them the diagnosis. So it has to come out as something that's just a random thought, gosh, I wonder. And that would then need to be specifically investigated in order to try and identify the cause. The sad part is, even with making a diagnosis, treatment is not very easy. It's not like hypertension, where we have loads of medications to bring blood pressure down. Pulmonary hypertension is very difficult. No easy answers, need specialist clinics, and what they will be having is an overwhelm with the numbers because they will not have had an increase in resources to cope with this surge of patients. Still, a long road ahead. And as I said, this is no longer just an idea. I've already assessed, teased out, diagnosed that this is going to be a problem. And the hope is that at least if we understand it, at least if we can potentially identify the people who are most at risk, maybe we can either slow the process or even in some cases reverse the pathology. That would be the ideal. A long road ahead. As I said, remember to like, subscribe, look in the description, see if you want to join us in any of the wonderful things that we're doing, and have a great evening.
A hero, an immune adventure. Humming Heroes, your lyrical guide to the body's defenders. Now on Amazon. Check the links below.